It's always nice for me to get these invitations and have a chance to get out, just because it gives me a chance to get out of Atlanta and see what people are really doing out in the field and what kinds of progress you're making and also what kinds of barriers and frustrations you're having to deal with. So thank you for that opportunity. But there's another reason that I'm very, very happy to be here in Albany at the New York State Health Department. And I do want to tell you a little story. Brad mentioned a mentor of his early on, and I'm going to when I was a medical student and a public health student, I, like many of us, had the good fortune to have a very, very good mentor. It was a man named Cecil Sheps, who at one point was a real giant in public health and the public health community and health services research. And he was a great help to me. He gave me a lot of very good advice, and he was also somebody who, when you were trying to do something, he could make it happen for you. And I followed a lot of his advice early in my career. I did a lot of things in medical school and training in public health. His advice, my decision to go to Montefiore and do my training in family medicine really came out of advice that I got from him. And then the third thing that he intended, he was a person who, when he gave you advice, he sort of expected you to take it, too. The third thing that he had in mind for me was that he felt that after I finished my training, I should spend time in a state public health department, in a really good state public health department, and kind of learn the ropes. And as far as he was concerned, the only state public health department that fit his criteria was the New York State Health Department. So that was where I was instructed to go. Now, unfortunately, it did not work out for me to come and do that, but it is really kind of nice for me to be here and have a chance to speak to you with sort of that previous history and story. And although I have never worked for the state of New York, I do now work very closely with many of you and many of the people, particularly in the cancer control programs. And, you know, Cecil Sheps was right. You have a premier state health department, I think, across all programs, but clearly in the area that I can speak most knowledgeably about in your cancer prevention and control work. And I think that Heather and Wendy have done a fantastic job of providing leadership. I'll talk a little bit about the program that we have funded where you all are working with federally qualified health centers across the state. That is something that is very, very important to CDC as far as what you learn from that project. Heather LeBlanc, who's now running your cancer prevention services, you know, although they are a kind of a gap-filling program, there is no state that fills the gap like New York does. And then Suzanne Kwan, we have these relatively new policy grants that only about a dozen states have gotten, and you guys, again, have been a real sort of trendsetter and leading the way in thinking about what the real policy opportunities are for state cancer control programs. And then finally, Maria Shimura, who's going to be speaking a little bit after me, and your state cancer registry. I mean, this is frequently looked at as one of the leading state cancer registries. So great work. I'm really delighted to be able to be here and talk to you a little bit about what I see and what we see at CDC as some of the future areas or emerging areas for work in cancer prevention and control. Let's see. Am I doing something wrong? Can you advance for me? Okay. So, thanks. So I just changed the slide this morning. I had a different picture, but this is baseball season, so I thought a baseball metaphor would be good. And this is a slide I've been using for several years. There is a lot going on, and all of these things that are on the slide, you know, when I think I first made this slide 2 years ago, it's all still very relevant. Those of us who work in public health have a lot coming at us. We've got, you know, really major problems with chronic diseases, cancer in particular, across the nation. We have an aging population growing at substantial rates that is going to mean we're going to be seeing more and more chronic diseases, and this is going to have a profound effect on our healthcare system. We have budget challenges. I think maybe states are beginning to recover from this a little bit, but I fear now we may start to feel some of the effects of federal cuts, so some of that's going to continue. So we have a big job cut out for us and limited resources to do it. And then in a more positive sense, we have health reform in the Affordable Care Act, which I think really opens some doors and provides some opportunities. Next slide. So I like to use this slide. I think it's a good metaphor for where we are in public health and cancer control. This is a historical slide of 4 workers from the Rocky Mountain Public Health Lab in Montana, and this is 1929-ish. And they've been out back in the day where public health workers went out into the wilds and collected samples. They were out collecting some kind of samples, and they've made it up to the top of this peak, and they're looking out and they're trying to figure out where to go next. And I think that's where we are. We've accomplished a lot, and we're at a very good place, but we're sort of looking out trying to figure out where to go next. And next slide. One of the things that we've done at CDC in grappling with this issue of, what do we do and where do we go next is began to define our work around these 4 domains that capture it. Not everything we do fits this, but I think this is a nice model, and I'm going to use this model to organize my talk and emphasize a few areas that I think are important for us to work in. But basically, these are 4 domains: policy and environmental interventions, health systems interventions, community and clinical linkages, and surveillance and epidemiology. So let me use that as a little framework. I'm obviously not in 20 minutes going to talk about everything we need to do in each of those domains, but I thought I might be able to hit on a few things that would be of interest to you all as you go forward and begin to implement your state cancer plan. Next slide. So this is familiar to you. This is the most fabulous. I go to a lot of states. This is the most fabulous. I guess this is your legislature. This is the most fabulous legislative building I've ever seen. And you guys do some really nice work here. And I do again want to reinforce what a nice job you're doing with the policy grant you got from CDC. I know you're doing a wide range of things, looking at ways to increase breastfeeding because of its role in potential cancer prevention, work around looking at ways to make healthy meals more available in various settings, and then work looking at some of the worksite issues and some of the opportunity for people to have time off so they can get cancer screenings. Those are very good areas to work at, and I think areas that people across the nation are kind of looking to New York for your example. Next slide. What I'd like to do, though, with my remarks about this domain of policy and environmental change is just speak a little bit about the Affordable Care Act and that being such an important federal policy, some of the opportunities I think it affords us. This is a picture of what I think are 3 of some of the most seminal legislation that's happened, at least in my life. Well, I wasn't alive when FDR was signing I'm not that old, the Social Security Act into place. But, that was a huge step forward in the real social safety net that we have in this country. And then the second picture is LBJ. I was alive then, signing into, he signed into legislation, both Medicare and Medicaid, which are such a huge part of our system now. And then I think equal to this is Barack Obama signing into law the Affordable Care Act. So there's some real opportunities here. And I thought I would just speak a little bit about this. So we've been spending quite a bit of time at CDC trying to think about how does this impact the programs that we funded for 2 decades now, dealing with providing care to mostly to women to get preventive services, clinical screenings for breast and cervical cancer. And so I thought I'd share with you a little bit how we're seeing this is going to pan out. This is a map of the United States, a study we commissioned from George Washington University together with the American Cancer Society, looking at how different states are going to fare and looking at how the eligible population will change in different states. And so as you see, the states with the greatest decline are in red and yellow, and then the kind of tan color and gray are significant declines, but less. And interestingly, New York State, because you have such generous entitlement programs and such a strong screening program, you're not going to see the same decline in eligibility that other states are, but you're still going to see a pretty substantial decline. Next slide. Then the other piece that came out of this study, which I think was really interesting, was looking at how does the population that we do continue to serve, or how does the population that is still not going to be covered with the Affordable Care Act, how does that population differ from what we've cared for in the past? So as you'll see here, a much lower proportion now of poor whites and poor blacks making up the pool of uninsured people, but a much greater proportion of people of Hispanic ethnicity. Another thing of interest is, people without high school degrees, really we're going to start to see some of the most difficult to reach populations being the populations that are still not able to get health insurance. People with limited English proficiency, I think some of that going back to there's going to be such a big proportion of Hispanics in this population. And then the bottom characteristic is particularly important. Medicaid, particularly for states that do the Medicaid extension, Medicaid will change dramatically. It will no longer be a program focused on women and children, which it has been historically. It's going to be a program that really reaches people who are poor, people who we have traditionally reached through our cancer screening program. So that gives you a little bit of a sense of what that population is going to look like. If I could have the next slide. And so I think there are some areas that we really need to focus on at the state health department level as the Affordable Care Act goes forward. I'm not going to talk about all these, but clearly Medicaid expansion. I mean, now we have this huge population that we used to have to kind of figure out ways to get coverage for who will have coverage. But that does not mean that these folks will take advantage of the programs that are available for them. This is a population that's hard to reach, that faces a lot of challenges in their everyday lives, and using the healthcare system and getting preventive screenings is often not at the top of their priorities because they have so many other dire issues to deal with in their lives. So there is still going to be a lot of work we need to do in public health to be able to reach these folks and get them to take advantage of these services. Uptake of the preventive care mandates, I think, will be a huge piece. Again, there's a huge opportunity there. And then finally, health information technology. And here I put this one on there specifically to make an allusion, I'll speak about this again in a minute, to the cancer registries. I think there's huge opportunities to really expand the work, automate some of the reporting we have in cancer registries, and really build that more into the healthcare system. Next slide. So that's a little bit about policy and environmental interventions or that domain. Let me speak now a little bit about health systems improvement. Next slide. This is something that we in state and local public health do very, very well, and that you all do very, very well through the breast and cervical cancer screening program. And this is a slide of a study we did a couple of years ago that basically shows that we can document that in the B&C program, women who get screened get the kind of follow-up they need. And I know that is a real hassle for you all to hunt people down and report back all the statistics that we require of you, but it's made a difference. We have shown that you can run a top-quality screening program that reaches underserved populations, and you can do it well, and you can not only get those people screened, but you can make sure that they then work their way through our very difficult and fragmented healthcare system and get them the care they need. So this is something that public health is poised to do as we go forward, and I think it's an area where we can continue to do work. And one area, next slide, one area that I think we can do a lot of work on as far as this goes is colorectal cancer screening. And there's an enormous amount of health systems improvement we need to do around colorectal cancer screening. And I just choose this as one example. This is something that you're going to see quite a bit of work coming out of CDC on in the next few months. And this is the issue of colorectal cancer screening and the use of different tests. So the good news in this slide is that colorectal cancer screening is going up. The thing that concerns me in this slide is that it's really going up totally driven by colonoscopy, and fecal occult blood testing is actually going down. And I don't think that, this is in no way to disparage colonoscopy. It's a great test. But I think to get the kind of results we need to see both of those tests going up. And so that's one place I think we need to work with the health systems around making sure that people understand, and particularly making sure that doctors are counseling their patients about the fact that there are several tests they can choose from. Next slide. This is important because many people prefer FOBT. Many people are not going to get a colonoscopy. It's not going to be acceptable to them. So we need to continue to do strong outreach work that there are two tests and that people have a choice in the way they can be screened. And there's some other reasons why FOBT, I think, fecal occult blood testing, is particularly important to us in public health. I'll get to them a little bit later in the presentation. So you'll see this is our publication that we've been doing every year as part of the vital signs series that Tom Frieden introduced to CDC when he came. And you'll be seeing in November, we'll be doing another one looking at colorectal cancer screening rates. And one of the big pushes, I hope, these things get micromanaged and have to be approved up the line, so hopefully we'll be able to keep some of the areas we're emphasizing. But one of the big pushes you're going to see in this is that we really want to communicate to the American public, to communicate to providers in the United States that there are several tests and that these tests need to be offered to the population. All of the tests need to be offered. Next. Surveillance and epidemiology. So this is my favorite study of the year. I never buy anything that costs money without going to Consumer Reports. And one of the themes that we've developed around surveillance and epidemiology is we need to put science into action. And I think this was such a great example of putting science into action. I mean, people go to Consumer Reports for information about things places they're going to spend their money. And Consumer Reports, as part of this big national campaign called Choosing Wisely, which is a big campaign that many of the medical specialties are participating in around a wide range of clinical tests. Consumer Reports did a very nice report about cancer screening and did a very nice job at explaining to people why breast, cervical, and colorectal cancer are cancers that it clearly makes sense for people to participate, are cancer screenings that it clearly makes sense for people to participate in. So it's these kinds of venues that I think we need to think about as we look at our surveillance and epidemiology work. Next slide. And one of the places that I think this is particularly important is in our use of the cancer registries. This is some work that we did at CDC looking at some of the ways that cancer registry data can drive policy. We looked at late-stage cancer diagnoses by state. As you all know, when you compare one state to another state, particularly for the states that aren't coming out well in the comparisons, that can really drive a lot of change. So I really encourage you to think about ways that you can use surveillance data, and you can use it, not just surveillance data, but please look at ways to use the cancer registry data for sort of pragmatic science to action type activities. It's a golden data system that we have that no other chronic disease has, and it's a system that I really think we need to start concentrating on how do we use these data in some of the most sophisticated ways we can. So I'm running a little low on time, so I'm going to have you skip this slide and the next slide and go to that slide. Let me talk a little bit to close out about community and clinical linkages. Next slide. So this gets back to the issue of screening, and there are a number of things that as we think about our screening programs and as we think about the fact that we may not have to put as much emphasis on actually paying for people to get screened, what does that open up the roles for public health and the public health community to do around cancer screening, and what are some of the other barriers that we need to deal with? There's a lot in this slide, but the big piece in this slide that I want to emphasize is this idea of trying to begin to transition from opportunistic screening programs to organized screening programs. Opportunistic screening programs are kind of how we do things now. People go to the doctor. Usually they go to the doctor for some other reason, like their foot hurts. And, while you've got them there, you take the opportunity to talk to them about getting screened, and you try to either do the screening then or bring the patient back for screening. That's a very good system. It reaches a lot of the population. But if we really want to reach the majority of the population who is eligible for cancer screenings, I think we need to look at more organized ways and not just depend on our relationship with clinical provider systems. Next slide. And so I get criticized sometimes that this is very ambitious to really think about doing cancer screening, outside of this traditional clinical approach. But I would say it's not unrealistic. And it's not impractical because it's what we've been doing for decades when it comes to immunization. A lot of people get immunized when they go to the doctor's office, but we have, because we've wanted to really reach a critical mass of the U.S. public, we've not just depended on the clinical system. We also give people shots in schools. We give people shots in work settings. We give people their immunizations in a variety of clinical venues. And so the idea is, are there ways we can begin to take cancer screening out into the community. And obviously, for cancer screening tests that require you to be in a medical facility, like having a mammogram or a colonoscopy, that's more difficult. But this goes back to what I mentioned earlier about FOBT, fecal occult blood testing. This is a test we can take out in the community. This is a test we can mail to people in their homes, and they can mail it back. So I think there's a lot of opportunities, and that's what I want you all to be thinking about as you think about the future opportunities. I'm going to try to move quickly here because I know I'm a little short on time. There's an enormous amount of capacity and expertise and skills and history that have been built through the breast and cervical cancer screening program. Brad mentioned it earlier on. My number one goal and passion is that we find ways to transition that program into new activities and new roles. What I don't want to see happen, which I think is such a great tragedy in public health, is when you build something and then you dismantle it and you sort of rebuild it somewhere else, because all of you are, out in the trenches, and, building something in federal, state, and local government public health agencies is a major task and takes forever. So let's take what we have and let's really look at ways to transition that so that we can continue to fill the kind of roles we'll need to fill as we move into a new age of health reform. Next slide. Let me segue back, though, to this idea that I think that what we're faced with now when it comes to cancer screening is sort of a dichotomy of two major areas we can work in. Patient-oriented approaches to getting people screened. These are very, very important, and I think some of the kinds of areas that we can make health systems more efficient at providing cancer screenings are on the left-hand side of the slide. But I encourage you really to think about ways that you can take more population-based approaches, and I think you've already done that very well. And some of those are, much more aggressive community-based outreach, enhanced use of electronic data, and population data monitoring. And so next slide. Just a couple examples of each of these. This is an example from a study we recently completed at CDC about the fact that, in this case, using community health workers, lay health advisors, in this case in the Hispanic or Latino community, can be very, very effective at getting people to participate in cancer screening tests. Next slide. This praises you all. Probably the best example in the nation of using electronic systems to track and make a difference with cancer screenings is being done in New York with this new innovative demonstration project you're doing with federally qualified health centers across the state to begin to build some of this into the medical home and look at ways it can be built into electronic data systems. And then the next slide. And then this idea of population monitoring, this is something we're really looking at very closely at CDC, and so I give you this last slide as an indication of some of the kinds of things you may be wanting to think about or position yourself forward. We're beginning to explore this idea of what would a national cancer screening registry look like, and I think the initial work with this will be very much kind of a feasibility study, kind of thinking about what are the pieces that would be necessary in that, what would the challenges be. So we'll do some sort of expert panels and thinking through this from a kind of top-down perspective. But what will happen after this is we'll be looking for some states to take this on and pilot it. So that's since you have all been such trendsetters and willing to kind of step out and be on the vanguard, I hope this is something you might be willing to think about is, are there some opportunities in New York State to think about how do we really monitor the screening status of the population, not of covered lives and healthcare systems, but of the population we're trying to reach, and what are the things we do to make sure those populations are getting the maximum health benefit that they can from cancer screening and from the wide range of other areas that we work in around cancer prevention and control. So I think that was my last one. Yes, that is. So that's a little bit of a whirlwind tour of kind of some of the stuff that's going on, some of the ways I think you can think about how you do your work in the future through as we implement the Affordable Care Act, and how you can maybe tap into organizing some of these things around these new domains as a way to think about and strategize your work as you go forward. Thank you for inviting me, and I look forward to having a chance to meet with some of you during the course of the day.